So our first speaker today is going to tell us about what goes on behind the scenes and what you've always wanted to know. We're delighted to welcome Ruaidhri McVey. Rory is a consultant gynaecologist and gynecological oncologist. He studied in the Royal College of Surgeons in Ireland and moved to Toronto to complete his gynecological oncology fellowship through the University of Toronto, based at the Princess Margaret Cancer Centre and the Sunnybrook Health Services Centre in Canada. In 2015, he returned from Canada to the role of Assistant Master at the Rotunda Hospital, prior to commencing independent practice at the Mater Hospitals and the National Maternity Hospital. So, Rory, you're very welcome, and the floor is now yours. So, we'll set you up here. That's it. Off you go.
Good morning, and thank you very much, Brian and Sharon, and of course Una, for giving us a wonderful introduction into the reason why we're here is to try and learn more and improve the care of all of our women and families who are affected by ovarian cancer. You've given a very nice introduction to me. I hope over the next short while to give you some of the insights as to what goes into the decisions into your care and your family's care. There's a background to all of this. I suppose I had a different order in all of this. When I first set the slide, my wife looked at it and said, no, surgeon has to go first, and then the husband and children come after that. But we're all people behind this, and what this means is that as patients, you're very much invested in your care, and then as the team who look after you, the doctors, the nurses, the allied health professionals, they're people too, and they very much get invested in the patient's care and what the right decision is. And sometimes those decisions are difficult, whether it's continuing with chemotherapy, making the decision to change track, and then revisit things in due course. We'll have a quick spin through some of the details behind ovarian cancer. I'll give you an indication of the process in terms of when we get told of a case like June, she pitches up, she's been seen by a number of other people. What happens before we make those decisions about having her treatment and what that treatment entails? And then we'll touch on, very briefly, hormone therapy for some of the women who are premenopausal and diagnosed with ovarian cancer. So it's the sixth most common female cancer. Most of the deaths are related to one particular type of cancer in ovarian cancer. It's rare cancer before the age of 40, and it's much more common in women who are postmenopausal. Overall, we say there's about a 1.5% chance of getting ovarian cancer over your lifetime. And we now know that the fallopian tube is probably the cause for most of what we now call ovarian cancers. So in the red area there on the disc, this high-grade serous ovarian cancer, and that's what the ovarian cancer that people read about. But we now have a much greater understanding that ovarian cancer isn't one disease. So June's disease may not be the same as another lady at the same table or a lady on the table next to her. There's 5 broad types of ovarian cancer. Then within those, we know that there are at a molecular level. So not just what type of cell makes the cancer, but even at a molecular level and a genetic level, that there is variation. And that accounts for some of the reason why, historically, we've put all of these cancers together and treated them as ovarian cancer as one disease. But we have much better understanding. And this is driving the type of care that we can offer and the type of information that we can offer to patients. So it's important that when you hear stories, the good ones and the not so happy ones, that these are individual stories and they're individual cancers, and they're not all the same. And so this, as we hear from the medical oncologist later on, is driving therapy and changing the way we're able to provide therapy. So we know from not only the short video on the Overcare website, but from some of the British organisations, that the symptoms are wide and varied. There is no single symptom. There is no herald sign that can tell us this lady has ovarian cancer. And typically, as June has, or as Una has alluded to, the story goes on for a number of months before the patient finally pitches up to a gynecological oncologist. And that's because the symptoms are so wide and so varied. And of course, as I mentioned earlier, there are multiple different types of ovarian cancer. So what happens by the time? First of all, you've gone to your GP, gone back to your GP and your pain is persisting, your symptoms have persisted or they've changed, and maybe you feel that you haven't been listened to, and maybe you've been referred on to a bowel specialist or a bladder specialist or a pain specialist or multiple different specialists. I'm reminded of a lady who I've dealt with very recently, and she had been to see 3 different specialists beyond her GP, and it was only after she'd had a scan and sort of as a last-ditch effort to say, listen, we don't know what's wrong with you. We've done all the other investigations, and of course we've identified an advanced ovarian cancer. This is a very typical story, and it can cause a lot of frustration among the families and the patients themselves, and of course the physicians and the teams who are looking after you are frustrated that we've missed it. But we also know that this is the case for the vast majority of the cancers that we see. Typically what will happen, you'll have a blood test, or there'll be an ultrasound, or there'll be an examination that will reveal something new. And from there, the story goes into the hospital. You get a letter sent in, and at this stage, we don't know that it's a gynecological cancer. We don't know that it's an ovarian cancer, so we have to decipher all the information that we have. And then we get a phone call, and the phone call will go to either ourselves or one of our specialist nurses, and the GP says, you know, we've been doing these tests, and now we've pitched up, it's different, and we think she's got an ovarian cancer, and can you see her quickly? And we know that the very best treatment is available to our patients is if we can centralize that care, and we're working on that, and we've changed that over the last number of years. A little over a decade ago, there were 17 different hospitals in the country dealing with ovarian cancer. And we've narrowed that down. We've narrowed that down to about 7, and these are centres that are now working much more closely together. So we know with the development of the NCCP guideline for the referral of ovarian cancers, that we can provide much better care, much better outcomes, and much better satisfaction for the patients and their families by providing care in one organisation. Now the frustration is that accessing that organisation can be difficult because it's funneled down to one stop, one location, and geographically it might be disparate from where you're living, and there's a frustration in accessing that. But we know that patients will do better, and we're able to provide better care by doing this, and that's the reason we do it. When you meet the clinical the secretary, and she's organising your appointment, and maybe there's a wait for another 2 weeks before you have an appointment, or a week, and this can seem like an eternity, especially when after potentially months that there's finally a diagnosis or a likely diagnosis of ovarian cancer. The clinics are already frequently oversubscribed, so you meet a team. We're supposed to have, for example, 20 slots in a morning to be able to provide the time and the care and attention to detail to the patients, but we probably already have 25 or 30 patients or more, and Nina will attest to this. So we're trying to balance the access to care, because patients feel happier once they're engaged with a process, versus knowing that we can see you, but we have to be able to initiate the therapy in a reasonable time frame. So you meet the clinic team, and it is a team. This is a village in terms of an effort to provide the patient with the very best care. There's the administration, the secretarial staff, the gleaning of all the information, of all the tests, and there's probably been many before you come to us. The nursing staff will have triaged the patients and prioritise them and try to give the very best care in the very best time frame. You'll meet doctors in training who are working with us, from the interns who are in their first year to specialist registrars who might be in their 10th or 12th year, before also engaging with the allied health professional, with the specialist nurses, and then the consultant who is the point person in terms of driving the care and in terms of organising the different methods and modes of treatment that will be required. And it's this time that there's doubt. Patients arrive, and there's in the back of many patients' mind, in retrospect, they say, well, I kind of knew. But it's probably the first time that somebody sits down and says, we believe that you have an ovarian cancer. We believe that it's advanced. We need some objective proof on this. And we would like from you who have come through this before to tell us how we can do it better. We know we don't get it right all the time, and this is the value of these forums, is that you can say, well, this was my experience, and if it had been done differently, I would have had a more personal, positive outcome. So that's the value of days like this. And we plan and direct the likely course of therapy. But at this stage, we still don't have a formal diagnosis, and we need something concrete before we initiate the chemotherapy, which was so important in Una's care, but is toxic. It has side effects. It's tough to get through. And the decisions will be down to, do I have surgery first or do I have chemotherapy first? And this is a long-standing debate. There are schools of thought on what is the best mode of treatment. And we know that for someone having surgery, the single most important thing is that we can remove all of the cancer, and whatever that entails. And frequently, those surgeries are very extensive, they're very debilitating, and patients have to be fit and well enough. So there is a difference in a patient who has never had any medical problems in the past versus somebody who has multiple medical problems and now, in addition to all of that, now has an ovarian cancer. So we try to balance these, and we try to identify the patients who will have the best outcome from their treatment. And we go to, only last week, many of us were at a meeting in Lisbon where we have world leaders in ovarian cancer, and we're guiding and we're having discussions, and we're basing it on objective information, because sometimes you can get personally invested in what you think the right thing to do for a given patient is. But when you look at objective information, so for studies that are done at international levels, where we're blinded to the details of why a decision is made, and then we look at the results in retrospect and say, well, this is the course of action that we should take for a given patient. And now we know that there are very many types of ovarian cancer. It's a much more detailed and fine discussion than maybe we might have thought 10 years ago. So in the investigations that happen, our CT scan, many of you will have remembered going through the big donut, sitting on the table, and somebody talking in your ear while you get an injection of a contrast that helps us define the extent of the disease from the radiological, so from the X-ray point of view. In addition to this, we do a blood test, a CA-125, and this is a marker for ovarian cancer. It's raised in many of them, but not all of them. So the context of that, the story from the patient, the examination of the patient, the X-rays, the blood tests, and of course sometimes if there's fluid, and we heard Una mention the fluid that was taken off her belly, that this helps us guide a definitive diagnosis. And even then, sometimes we don't always get it right, but we get it right most of the time. Occasionally, we don't identify an ovarian cancer, and it can be from another cell in the body that has become malignant, in which case the treatment should be different. So, as I tell many of the patients who I meet who are very frustrated if they've seen their GP a couple of times, maybe they haven't felt listened to, they've seen another GP, they've seen a specialist, they've had x-rays, they've had colonoscopies, they've had other examinations, and still this hasn't been identified. A year has passed, and in retrospect, they felt, had a year ago, if I had known, would things be different? It's much more important to make the right decision than the wrong decision quickly. And this is the reason why we have a very structured approach to it. It can be frustrating. It's the reason why we direct all our care from larger organizations, and it's the reason why patients sometimes have to travel. All of our patients who come through us, we have a multidisciplinary team review. And what that means is that if the patient gets sent to me or Noreen Gleeson or Bill Boyd or Michael O'Leary in Galway, that it's not Michael O'Leary's opinion you're getting or Matt Hewitt down in Cork. You're getting the opinion of the group there. So for the other gynecologists in the group, the medical oncologists in the group, the radiologists, and the medical oncologists. And together we come up with a plan that's an institutional plan rather than just a named individual. So that removes some of the personal decisions that can be made, some of the decisions that can cloud your judgment, and gives you the very best chance of a good outcome. Historically, once you've made a decision for someone to have an operation, the patient will be brought in the night before, then a whole gamut of tests will be done. We've changed this relatively recently in Ireland. At the time when I started the matter, well over 10 years ago, this is what happened. Patient came in at 5 o'clock that evening. We found out at 4 o'clock that there's a bed available. Patient comes in, and then there's a big race to get the additional blood tests, x-rays, ECGs, to make sure that they were suitably fit and safe to have an operation. We've changed this now, so patients have to come another visit to the hospital, but all of those tests are done in advance. So it's changed the way we use beds in the hospital. We know that there's a shortage of beds in the system, so we're trying to use this the most efficient way as possible. In St. James's, where I worked before, again, you'd have patients coming in the night before, and we changed it so they would come into clinic the day before. We would sit down, have a conversation, and we'd talk about the operation, what they can expect, and the test that needed to be done. When we talk about why somebody has surgery versus why somebody has chemotherapy first, we want to be able to be confident at the time of their surgery that we can remove all of their cancer. So if we don't believe that even with the most advanced cancer surgery that we can remove all of the cancer safely, well, then that patient should have chemotherapy first. And so that's what the chemotherapy does, is it shrinks the cancer, it makes the surgery easier, it makes the surgery less complicated. The complications after surgery are less. And so for that reason, we do this with the chemotherapy first, but we would prefer to operate first in many of these patients. And what's the aim of the surgery? The aim of the surgery is to remove all of the visible cancer, and whatever that entails. And for somebody who hasn't had chemotherapy before, on many occasions, they'll require a portion of their bowel to be removed. And that puts it into a level of complexity that's probably the most complicated gynecological surgery, probably arguably some of the most complicated general surgery that's done. And so it's a big decision to undertake the surgery. It's a big decision for the patient, for their families, their expectations of what happens after the surgery. And we call this radical cancer surgery, radical debulking surgery, or cytoreductive surgery. It all means the same thing, and the aim is always the same, to remove all of the visible cancer. And we talk about how do we consent somebody? They've met somebody for the first time, maybe for the second time, and how do you tell somebody that they have a 1 in 3 chance of having some sort of a complication, whether it's a kidney infection or a wound infection, skin infection, or a chest infection afterwards, or a prolonged stay in hospital, or they have a 3 in 100 chance of having something really serious, like an extended stay in ICU, or a second surgery, or an unexpected bowel injury, or bladder injury. So one of the ways when I worked in Toronto is the hepatobiliary, the liver specialist group, had developed a patient education program online, and they were able to demonstrate the complexity of the surgery through animation and through the use of x-rays and through the use of real-life surgery. And this is something that we're going to try and adapt for an Irish context. And it's something that I would hope that in due course that we can have a much clearer way of explaining to patients. And it's something that I'd love to hear feedback on is how do you think you knew everything about the surgery, and how do you think we could have explained it to you better? I'm almost certain that everybody has an opinion on that. Same day surgery. I alluded to it earlier. Patients come in the night before. Now they come in the day of surgery, and it can seem almost overwhelming to come in the morning and know that you're going to have a major life-changing operation. And you come in first thing in the morning, you probably haven't eaten much the night before, you're told you can fast, but you can drink some water. But the reason behind this is about maximizing the efficiency for the hospital, which allows us to provide the best care. And we know that there's good evidence behind this. So this is the standard of care for patients across Europe, across Australia and North America, where most of our oncology specialists have trained internationally. So we're guiding the care through what's happening elsewhere around the world. The frustration often happens when a patient goes, well, I'm here in the morning and operation doesn't start till 2 o'clock. Like it's why do I have to do this? And that's a function of how the hospital works, and I suspect in time that will improve, where we're able to give patients a better understanding of the time of the day that they'll have their operation. Normally we try and do smaller day case operations first thing in the morning so they can go home that day, and then allow the bigger surgeries to be done later in the day. But it does mean a long day for that patient and their family. St. James's have a remarkable scenario where they have availability for a dedicated day case surgery suite. So those small cases are done on a different day, which allows those very big cases to start first thing in the morning and then another case later on that day. So it gives much better indication to the patient about how things will work out. And of course, we don't know at the time of doing an operation how long it's going to take. We can have an indication. It could be 2 hours, it could be 4 hours, it could be 8 hours. So to inform you guys, to the patients, their families, we have to try and inform ourselves and put ourselves in the best position to provide the very best care. So what happens in theatre? Patients, families often ask, so what time can we expect to speak to mom or my sister or my mother or grandmother? And it doesn't just happen that the surgery's going to take 2 hours and so it's now 9 o'clock, can I talk to her at 11? The process gobbles up most of the day for these very big surgeries. There's a series of checks and rechecks. The patient comes down to theatre, meets the anaesthetic staff, meets the dedicated nursing staff. Patient goes to sleep. It can take 45 minutes for the patient to go to sleep and be set up so that they're safe to have these very big operations. And then their operation itself, as we mentioned, can take 2 to 4, 6 hours. And then the patient has to be woken up, brought likely to a special care ward, whether it's intensive care or high dependency. And that, again, all takes time. It's a long way from George Clooney and Chicago Hope. And what does the surgery entail? As I mentioned, we aim to take out all of the surgery. And so when a patient says, well, where was the cancer? From our point of view for ovarian cancer, we talk predominantly about the high-grade serous ovarian cancer, that red circle that you saw earlier. As soon as it's out beyond the ovary, we consider that all of the internal portion of the abdomen is involved. So anything that's visible to the naked eye, we try to remove. And if that means removing a portion of your bowel, then that's what we'll do, as long as we believe that the patient will benefit from it and that the patient is able to undergo these very big operations. So we'd remove the uterus, the tubes, the ovaries, and then this fatty apron called the omentum and any fluid that's there. And on occasion, we'll also remove portions of the spleen or the little segment of the liver or the diaphragm. So they are very extensive procedures for some women. And who makes the rules? Who's guiding us in all of this? Another little plug for this meeting that we're doing in December. This is not Ruaidhri McVey's view on how things should be managed for ovarian cancer. These are very considered approaches that are done at an international standard, and they're based on the most objective information that we have. Now, that's not always the ideal information, but it's the best we have. And we guide our care from organizations and institutions and specialists who've dedicated their lives to improving the care. And there will be differences of opinion on minor details, but the trajectory of care is the same wherever you are. And so, as one little example, hormonal therapy for women who are premenopausal, historically we've kind of said, well, you probably shouldn't be on hormonal therapy if you're premenopausal and you have a diagnosis of ovarian cancer. Only last weekend at a meeting, Sarah Temkin very kindly shared with me a couple of her slides about this very topic. And so we know hormone replacement therapy is a very controversial area. It's a very controversial area for women with cancer. And it's been around for very many decades. There was a number of scares in the late 80s and 90s where a lot of women were on hormonal therapy, then they stopped it, and the changes that we're seeing in terms of breast cancer incidence and ovarian cancer incidence. But what happens for a lady who's 40, 45, diagnosed with ovarian cancer and has a hysterectomy and is immediately put into menopause? We know that HRT has fantastic positive side implications for women who take it. Benefits in terms of hot flushes and mood swings and cardiac protection, bone protection, and dementia. Again, remembering that ovarian cancer is a very heterogeneous, in other words, there are very many different types of ovarian cancer that we're only now beginning to have a better understanding at a molecular level. So do we think it's reasonable to take HRT? There's a suggestion that it increases some of the risk for patients with ovarian cancer. But if you look here on the right side, the little tiny bar is the increased risk of taking a hormone replacement therapy. The third bar in is that same lifetime risk if you're a flight attendant. So you can see it's a much bigger risk to be a flight attendant than it is to take a small amount of HRT for some women. But yet our perception of risk is very different. We know that women who are 800 to 900 women out of 1,000 will experience good relief from HRT. So it's valuable to consider the patient as a whole entirety. We're trying to balance the symptoms related to cancer, the symptoms related to the treatment, and then there's a psychosocial, the emotional, and the consequences for the family. So the perception of our treatments is changing with time. The perception of how we explain this to our patients is changing with time, and the information is there to try and improve. So without going into the details of HRT for women with ovarian cancer, we know that for many women it may well be appropriate, it may well be reasonable, and the blanket historical ban on HRT is probably time for a renewal. And this is information that comes when the team goes to international meetings, and this is the reason why sometimes there's doubt and question and uncertainty in some of the decisions, because not all of the decisions are crystal clear. They're subtle, they're individual, and we try our very best to personalise and individualise the care. On that note, I'll let you go. Thank you very much.